I am Dr. Indu, doing my final year postgraduate in Government RSRM Lining Hospital. My topic is on semen analysis. Next slide. The semen analysis plays the key role in the evaluation of male infertility, as male infertility contributes about 20% of infertile couples. The initial one properly performed semen analysis. If the results are abnormal, we should repeat the semen analysis after at least 4 weeks. And as we all know, the scrotal temperature is about 2 to 4 degrees Celsius below the core body temperature, which is maintained by the pampiniform plexus of the veins. Now, what is semen and what are its components? Semen, it mainly constitutes about 5% of the spermatozoa, and the remaining 95% is contributed by the seminal fluid. The seminal fluid is majority, in turns the seminal fluid is contributed by the seminal vesicles of about 65%, which produces an alkaline secretions and contains fructose, and the prostate produces about 20 to 25%, which has mainly acidic secretions, and the 5% is contributed by the bulbourethral glands. So, when the tests of semen function are to be performed, it is critical to separate the semen within 1 hour of its collection, as it is destroyed by the non-sperm cells. The phases of semen secretion. Semen is usually secreted in 4 stages. The first stage is a pre-ejaculatory fraction, which contributes only little bit by the corpus and the Litters glands, whereas the preliminary function is contributed by the prostate, which has its acidic secretions. The main fraction is by the seminal vesicle and by the testis and epididymis, and the terminal fraction is again by the seminal vesicle and which gives gelatinous in consistency. So now, pathway of the sperm. The sperm is generally produced inside the testis. From there it migrates to the epididymis, where it is stored. From there it travels via the vas deferens, enters into the seminal vesicle and is joined by the ejaculatory duct. From there it enters into the prostate, and contributed by the bulbourethral glands, it exits via the urethra. Now, what is the ideal process of semen collection? It should be collected after an abstinence period of 2 to 3 days, and ideally it should be collected by masturbation. Some other techniques of collection are coitus interruptus and through condoms, but masturbation is ideally done, and in a wide mouth container, in a laboratory, in a private room, and it should be labeled by name, age and the date of collection of the semen. Now, the recent WHO guidelines for the semen parameters are the volume should be 1.5 ml, the sperm concentration should be 15 million per ml, total sperm number should be 39 million per ejaculate, and the percentage of motility is 40%, with progressive motility of 32%, with morphology is contributed only by 4%, and the vitality of the semen is by about 58%. So, if the results of semen analysis are abnormal, it should be repeated at least after 2 to 3 weeks. If it is normal, the single semen analysis is enough. Now, moving on into individual parameters. The macroscopic examination. First, looking at the color of the semen, it should be opalescent white grey in color. If it is yellow, it might be a normal urine, or it might be jaundice, or it might be due to leukocytospermia. If it is red, that is known as hemospermia, which is because of prostatic infections and injuries. Now, moving on into liquefaction time. The semen analysis usually begins after the liquefaction, which is usually 15 minutes to 30 minutes, and maximum up to 60 minutes, where the semen is converted from a coagulant mass into a homogeneous watery mass because of the acid secretions by the prostate. And microscopically, we can confirm the liquefaction by the presence of the immotile spermatozoa begins to move. Now, moving on to semen viscosity, it is usually graded as 0 to 4. After liquefaction, the viscosity is examined by gently aspirating the sample in a wide bore needle and observing the length of the thread. If it is more than 2 cm, it indicates it is a hyperviscous semen, and hyperviscosity can interfere with sperm motility and sperm concentration. Now, moving on into semen volume and pH. The semen volume, majority is contributed by seminal vesicles, which share a common embryology from the vas difference. So, if there is congenital bilateral absence of the vas difference, there might be associated decreased semen volume. And seminal vesicle secretions, as I said already, it is usually alkaline because of the seminal secretions and it contains fructose. So, causes for decreased semen volume, it is mainly because of failed emission, incomplete collection and shorter abstinence. And some pathological causes include congenital bilateral absence of vas difference and ejaculatory duct obstruction and hypogonadism, which usually characterized by low volume semen with low fructose and acidic semen. And in case of retrograde ejaculation, the volume is usually less than 1 ml, which is diagnosed by post ejaculatory urine analysis, which has sperm in the urine. Now moving on into microscopic examination. Initially the sperm concentration, it is the number of spermatozoa per unit volume of the semen or the ml. It is more than 15 million per ml, whereas the total sperm count is the total number of spermatozoa in the entire ejaculate, which is about more than 39 million per ml. So total sperm count is calculated by semen volume into the semen concentration. Now what is azoospermia? Azoospermia is absence of sperms, which is it should be documented at least 2 occasions. It may be obstructive or non-obstructive causes. Obstructive causes mainly because of severe infection, congenital bilateral absence of vas and some iatrogenic injury, whereas non-obstructive causes mainly because of testicular failure, which may be primary or secondary. Now what is oligospermia? If the sperm density is less than the normal value, that is 15 million per ml, it is oligo, whereas severe oligospermia is less than 5 million per ml. Now, how to approach a case of azoospermia? Whenever there is azoospermia, we should rule out the congenital bilateral absence of vas, which if present, it indicates the cystic fibrosis transmembrane conductance regulator mutation. It is congenital bilateral of absence of vas is usually diagnosed by absent kidneys, as it is associated with renal agenesis. If the vas is present, then we have to proceed with the semen volume. If the semen volume is less than 1 ml, then we have to go for the post ejaculatory urine analysis. If there is presence of semen in the post ejaculatory urine analysis, it indicates the retrograde ejaculation. If the semen is absent in the urine, it indicates some other causes like ejaculatory duct obstruction. If the semen volume is more than 1 ml, then we can go for a hormonal analysis. Now moving into sperm motility. Now motility is recognized as the most important predictor of functional unit of the spermatozoa. So the percentage of total sperm exhibiting motion should be about more than 40%. The probability of conception increases with increasing motility. So total motile sperm count is calculated by the total sperm count into the progressive motile count. So it usually estimates the total number of active sperms in the ejaculate. As per guidelines given by WHO in 2010, the motility is classified as progressive, non-progressive and immotile. Progressive is which moves actively, whereas non-progressive, it exhibits all other movements except the forward progression, and immotile is there is no movement. And what is asthenospermia? It is the poor sperm motility. It is less than 32% of progressive motility. So it may be because of testicular or epididymal dysfunction, sperm autoantibodies, genital tract obstructions, varicocele, and sometimes because of prolonged abstinence, and primary ciliary dyskinesia, which is known as the Cartagena syndrome. Now moving on into vitality tests. Whenever we find when there is no motile sperms, we have to differentiate the viable immotile sperms from the dead sperms, which is nothing but necrozoospermia. It is usually identified by the 2 methods, eosin or the trypan blue stain, and the host, which is nothing but hypoosmotic sperm swelling test. Eosin test, where the dead sperms will take up the stain and it will turn into pink, whereas the live sperms will be colorless. And moving on to the second test, hypoosmotic sperm swelling test. It is based on the fact that the intact cell membrane will take up the fluid under hypoosmotic condition. Thus, if a live sperm will absorb the fluid and the tail region will be swollen, whereas in case of abnormal sperms, it does not take up the solution. Now moving on to sperm morphology, and it reflects the quality of spermatogenesis. Morphological abnormality is known as teratospermia, which is characterized by location involving either the head, neck or the tail of the sperm. It is usually associated with varicocele and primary and secondary testicular failures. Isolated teratospermia is usually not an indication for ICSI. According to 2021 guidelines, WHO guidelines, 4% is the strict criteria named after Kruger strict criteria. Only 4% of morphology is enough. And each and every part of sperm is important for its fertility. And strict sperm morphology remains the best available predictors of sperm function. Now these are the various morphological defects. The round cells, it includes the presence of non-sperm cells, especially the epithelial cells, prostate cells, some immature spermatozoa and leukocytes. Usually it should be less than 5 ml. If it is more than if there is more than 1 million per leukocytes per ml, it indicates leukocytospermia, where they should be evaluated for some genital tract infections. And in a recent study, where there is a computer assisted sperm analysis, as the name suggests, it is a computerized assessment of the sperm analysis. It is an automated and objective evaluation of sperm concentration and motion characteristics, where we can see the microscope is connected to the computerized system. It is a digitalized video for analysis. It uses a fluorescent DNA stains. It evolved through advances in devices to capture image from microscope. I'll just skip this slide. Advantages of CASA, it is usually a high precision quantitative assessment of sperm kinetics, and inter-observer bias can be eliminated, and results are usually accurate and reproducible. Whereas the disadvantages of CASA is, if there is a small change in the instrument settings, it can cause profound change in the results. If there is hyper illumination, even the water droplets and the the dust particles will appear as immotile spermatozoa, and it might be calculated as immotile sperms. Now, out of the competing interests, the Bioservice Scientific Laboratory is a contract research organization which is serving a number of industries and conducting experimental studies including CASA. Now, researchers have observed the negative effect on sperm motility parameters, viability and reactive oxygen species generation because of electromagnetic radiation which is being generated by the mobile phones, and prolonged sitting with laptop on the lamp even increases scrotal temperature and thus inhibits the spermatogenesis. Thus the take home message is, male infertility contributes about 20% of the infertile couples as recommended by WHO, and single semen analysis is not enough in case of an abnormal results. There should be a minimum abstinence of 2 to 3 days, and the collected semen should be examined within 1 hour. And the motility and vitality characteristics of the sperm are more common than the azoospermia, and as we should avoid using mobile phones and laptops. Thank you.
Yes, doctor, it was a good presentation.
Thank you.
Any questions, ma'am? Anybody? I'll just add one thing. Like everywhere you have mentioned oligospermia, and it should be oligozoospermia.
Okay.
Always.
Okay.
Oligospermia and oligozoospermia are two different entities.
Okay.
And in that blood and semen, you have to, being gynecologists, they have to remember about persistent Mullerian duct syndrome also. That is one of the causes where you get blood and semen. When you rule out other things, this is one entity which we have to keep in mind.
Okay.
Otherwise, it's a vast thing where you have to, actually it should have been a comparison between the 2021 and 2010. I think we didn't do that in this presentation, I think. Otherwise, okay, fine.
Thank you.
Loud enough, I guess. I'm going to take a few minutes on your presentation because your topic was 6th edition, while you presented mostly from the 5th edition.
Yeah.
So 2020, thank you. The 2020 is not that it's gone, but then 2021 has come. It is very much an updated edition. When the 2021 has come, you forget about the 2010 and you go only to 2021. The salient features of the 2021 editions are this. But before that, I want to definitely emphasize on one thing. See, when you talked about the presentation and the cutoff value values, you said 4% is enough. It is not enough. You know, all the cutoff that is given here is the 5th percentile. That means if they have taken 100 people, 1,000 people who have fathered children, and then this is the minimum lowest. It's like the 35% mark in 12th standard. It is not the 90% mark. This is the 35% cutoff to pass. If you have this, you pass. Your chances or probability of fathering a child is there. But below that, the probability is very less. So it is only a statistical calculation that we have seen, and that also is, we don't have any Indian data in it. Because we didn't present, not that they don't want to take, we all have not presented anything at all, we have not published anything at all, and that is why it's not there. From last 2010, they've actually included Chinese data, little bit more of European data and everything because they were published. It is not there because we didn't publish. So, one, we should publish. B, that is not enough. That is the 35% cutoff mark for you to pass, such that your probability of fathering a child is more if your parameters more than this. That's all. Please always remember that. In the 2021 guidelines, the beauty is this. They have thrown out so many of the useless tests that we used to study, like the Zona hamster thing and all that nonsense. They've thrown it away. That's very good that they've taken out most of the non-clinical tests, and they've included the newer ones such as the DNA fragmentation, and they've also segregated the thing between the basic analysis, and the advanced analysis and advanced selection. I think the 2021 is a manual. It gives a step-by-step of everything that we do. It is a manual for us to keep in the andrology lab and go through it. So it's taken away a lot of things that we don't need, and there has also been a distinction saying that it is not like your infertile or fertile, they have given a graded one. And yes, there is actually a free presentation online about the 2021 CME. So 40 minutes or 1 hour thing, it's freely available. Please go and read, listen to it. It gives a lot insight into the newer guideline that we have. Sorry, thank you.
Thank you, Dr. Priya. As she said, most of the values were only from the previous edition. Now you have to correct your presentation or anything in future. Okay, thank you.
Thank you. Thank you. I would like to introduce our next speaker, Dr. Indra. Madam is a director and fertility consultant from Sai Fertility Center and Hospital, Chengalpet, and she is a consultant in KR Hospital, Tirukalakuntram. Madam has completed her undergraduation from Tirunelveli Medical College and MS OBG from SRMC. She has done a diploma in reproductive medicine in Germany and masters in reproductive medicine from British Fertility Society from UK. And she is a member of FOXY and European Society of Reproductive Medicine and Embryology. We welcome you, ma'am.
Thank you. Good morning, everyone. My sincere thanks to the whole COGS team for giving this wonderful opportunity. Now, infertility is a global health issue affecting millions of people of reproductive age group worldwide. So, God created man in his own image. In the image of God created he him, male and female created, and God blessed them, and God said unto them, be fruitful and multiply and replenish the earth and subdue it. The landmark event in reproductive resolution is on 25th July 1978, when the world's first test tube baby was born. Now, what is the normal need for the reproduction? One man, one woman, one sperm, one oocyte. When things go wrong here, the only way out to conceive is through a third party, where the third party reproduction steps in. What is third party reproduction? The reproductive process when it goes beyond the traditional father-mother model. And ASRM defines as arrangements in which the intended parents collaborates with the gamete donors. Coming to the choices in the third party reproduction, there are 4 different choices: oocyte donation, sperm donation, embryo donation and surrogacy. Egg donation has revolutionized fertility for many women whose egg reserve has diminished in both quality and quantity. With increasing age, the ovaries run out of eggs. For these women to conceive, the only way out to use is the donor eggs. Common reasons for the oocyte donation, as we all know, the poor ovarian reserve, premature ovarian failure, aged women, oophorectomy cases, genetic disorders, recurrent IVF failures and recurrent pregnancy losses, and there is also an increased incidence of poor ovarian reserve and failure, cancer ovary and operated or irradiated cases. And the oocyte donation process, we do it in 3 stages. It takes place: the donor recruitment, the donor screening and donor matching. Now, who are the donors? How are they tested, and how do I pick up a donor? Coming to the selection of the donors should be recruited from the National ERT registered agency. Detailed history, psychological evaluation and counseling of the donor should be done. The consent of the donor and the consent of the donor's husband is also a must. And classification. Coming to the classification of the donors, we have 2 groups: the anonymous fertile donors and anonymous infertile donors. Anonymous fertile donors who claiming the monetary compensation, and anonymous infertile donors are the women undergoing IVF. Some may agree to donate their excess eggs to infertile patients. Using spare oocytes has its own advantages, like donors doesn't have to suffer any additional risk, and egg sharing reduces the cost of treatment. However, the disadvantage being donation of oocytes from an infertile woman has lesser success rate. Coming to the donor screening, as we all know, we do all the tests for a donor, from the complete blood count with platelets, serological investigations, cervical cultures for gonorrhea, pap smear, and the transvaginal ultrasounds. And coming to the matching, and how do I match a donor? The donors are matched as closely as possible with the recipient couple for characteristics such as hair color, eye color, occupation, and medical matching for blood grouping also should be done. And the donor should be aware. We should educate the donor, and donor should be aware, and they should give consent to the side effects of the hormonal injection, anesthesia related risks and OHSs. And the success of the oocyte donation is, overall success rate of the donor oocyte cycle is around 55 to 59%, whereas the self cycle is 40 to 50%. And age of the oocyte donor is the primary contributor of the cycle. Coming to the sperm donation, the use of donor sperm has been practiced for over a century. Since the late 1980s, with the emergence of HIV, the donor insemination has been performed only with frozen and quarantined sperm to allow for time to test the donor. FDA and ASRM guidelines recommend that the sperm be quarantined for at least 6 months before being used. The sperm donor will undergo semen analysis, and the sample will be thought to evaluate the post-freezing and the post-thawing semen parameters. The donors are selected only if the post-thaw semen parameters meet a minimum standard. In general, the specimen should contain a minimum of 20 to 30 million motile sperm per millimeter after thawing, and the post-thaw motility is the range of 25 to 40%. In addition to the medical information that is obtained from the donor, the donors are asked to provide detailed information about their personal habits, education, hobbies and interests. Sperm banks may provide pictures of the donor and video or audio tapes from the donor. Coming to the embryo donation, refers to the embryos created for a specific couple using the donor eggs and the donor sperm in order to achieve a pregnancy. Common reasons being untreatable fertility issues, recurrent pregnancy loss, recurrent IVF failures and genetic disorders. And based on the new ART rule, the current status says the ART clinic should provide all the following information from when they come for the physical inspection by the National Board. Enrollment of the commissioning couple and the gamete donor is a must, and the procedure being undertaken should be registered. The outcome of the procedure, if any complications, should be entered. Written and informed consent of the parties seeking ARTs is must. The insurance coverage of a prescribed amount, the amount has not been mentioned, for a prescribed amount for a period of 12 months in favor of a oocyte donor by the commissioning couple recognized by the Insurance Regulatory and Development Authority Act. You can obtain semen from a male between 21 years and 55 years of age and obtain oocytes from a female from 23 years and 35 years of age. Should not supply the sperm or oocyte of a single donor to more than one commissioning couple, and the donor shall donate oocytes only once in a lifetime, and not more than 7 oocytes can be retrieved from the donor. All the unused oocytes shall be preserved by the bank for use for the same recipients or can be given for research to an organization registered under the Act. Not more than 3 embryos may be placed in the uterus of a woman undergoing the treatment cycle. Women shall not be treated with gametes or embryos derived from more than one woman during any one treatment cycle. The gamete of a donor or embryo shall be stored for a period of not more than 10 years, and at the end of such period, the embryo shall be allowed to perish or donate for a research organization. Egg recipients and the father of the child or the legal parents. Father must pay the child expenses even if he claims a divorce prior to delivery. Anonymous donors, the donor identity should not be revealed. Any medical genetist, gynecologist, RMP or any person shall not abandon or disown or exploit the child born through ART. If done, shall be punishable with a cash fine and imprisonment. Coming to surrogacy, it's a fertility treatment in which a woman other than the intended mother carries the pregnancy to term and delivers the baby for the intended parents. This technique is one involving a greater degree of complexity from the ethical, psychological, moral and technical point of view. The 2 types of surrogacy, the commercial and the altruistic surrogacy. Commercial is when the surrogate is paid and compensated for her services over and above her medical expenses. And the altruistic surrogacy is when she is given no financial gain for carrying a child, only realistic out-of-pocket expenses are covered by the intended parents. And coming to the common indications of surrogacy, we classify into the patients with uterus and without uterus. With uterus, repeated miscarriages, medical conditions in which the pregnancy is contraindicated like chronic kidney disease, Eisenmenger syndrome, and the patients without uterus like Mullerian agenesis, MRKH syndrome, and the hysterectomized patient for obstetrics or gynecological reasons. Conditions for surrogacy: the surrogate must be married, having her own child, and she should be around 25 to 30 years of age, who have not provided her gametes, and medical and psychological fitness certificate is a must. Eligibility certificate for a surrogate from the medical board of the district headquarters hospital is a must now. An affidavit of parentage and custody from metropolitan magistrate or a judicial magistrate. Intending couple should insure for a surrogate for 36 months covering the postpartum complications. The success rates of surrogacy procedures are entirely dependent upon the overall success rates for the given ART facility. At Experience Center, the process of IVF surrogate pregnancy has thus far been uncomplicated and gratifying. Nonetheless, all programs involved in this type of arrangement should adopt strict guidelines with direct evaluation and monitoring of all the procedures involved in the care of the patients for the best. The rights of the child. The child born through ART shall be deemed to be a biological child of the commissioning couple, and thus a child shall be entitled to all the rights and privileges available to a natural child. The donor shall relinquish all the parental rights over the child which may be born from his or her own gametes. The options available through third-party reproduction provide many couples the opportunity to make their dream of parenthood a reality. The comprehensive nature of the screening and counseling of the intended parents and their donors or surrogates ensures that the process meets the needs of all involved. Finally, as third-party reproduction is more widely used, there continues to be a broader understanding of the ethical, moral and legal issues involved. Ultimate goal of a physicians, mental health professionals and attorneys specializing in reproductive law is to enable this process to move forward as smoothly as possible and bring joy and satisfaction to all parties involved in ensuring the conception and delivery of a healthy child. Expert counseling to be included at every step with third party helping in reproduction. Aim has to be making a family and not breaking or weakening the relationship of intending parents. Thank you.
Ma'am, it was a good presentation. Only thing that we have to know is nothing can be done without the knowledge of the government here afterwards. The oocytes, it cannot be donated, it cannot be given to anybody, or it cannot be even given for research without the knowledge of the government. It has to be intimated, whatever you are retrieving, and including the scan pictures. These has to be recorded, because we come across several institutes which don't have the scan records with them. These are very, very important, and I think everybody should go through our own state's protocols also. I think day before yesterday, Dr. Priya posted a recent one regarding oocyte donation. I think I'll be forwarding it to the COGS team also. It's very, very important, because whatever the state authority tells us is also very, very important, along with the national registry. This is evolving, and it has not come to a proper conclusion yet. So until then, we have to be very, very alert, doing whatever we have been doing before and now and future. This is the most important thing. If all of us understand that nothing can be done without the knowledge of the government, and we self-restrict ourselves and self-regulate ourselves, it's the most important thing that can be done in this third-party reproduction. Thank you.
There is a restriction for the oocyte donor that she can give it only once. What about the male specimen? It is the same. It was the same. Yeah. It is the same even at present for males. Before, so it's going to be a little bit difficult.
Madam,
Once in this lifetime.
Actually, ICMR guidelines said up to 25 viable pregnancies it can, because ICMR has gone now. They non-existing now, but till the ART new registry to 2022K, it was in like 25 successful pregnancies.
So restrict the number of your third party. And one thing I just want to add up from Dr. Shanti is, until the government gives you any oocyte donor, please don't do any oocyte donation as of now. So stop everything. Stop. Please abruptly stop everything. The government gives you X, please take it. Otherwise, please stop everything. There is no need for you to get your licenses cancelled for your patient to get pregnant.
Is it necessary that all married women should only donate oocyte, or anybody can donate oocyte?
Yes, married women only can donate oocyte with the consent of the husband. She should have one child.
Married with the consent of the
Husband,
One child.
Or I think it also can say, if the woman is married, has a child and divorced, she should give the divorce papers.
It's not that she should have one child. Marriage is compulsory.
Marriage is a compulsory with the husband's consent.
With the husband's consent. It was always is there. It was always like that. You just didn't notice it. Now you are noticing it. Husband's consent is always necessary for using their eggs. If she is divorced, you have to have the divorce papers in your hand. If she is separated or whatever nonsense, legal status not known, please don't take the donor. From now on, please take donor only with the government gives. Otherwise, just keep quiet.
Yeah, that's all.
And your
Thank you.
Age limit, ma'am. Is there any age limit?
23 to 35 years for the
For
donor.
the male. For the
For
donor.
the male to give the semen.
Donor.
I saw the 55, it's from the Indian registry.
Yes.
Ma'am, what about the female, ma'am? Is it the same age limit or it's different?
23 to 35 years.
25. Ma'am, you told about all the semen should be kept in the, I think, frozen, and then only
Frozen
can
and
be used for
quarantine
IUI.
schools for 6 months at least.
Yes, ma'am. To know the HIV status.
Yes.
Thank you.
Thank you.
I think we'll have a good session with Dr. Priya Kannan here around. She's been the forerunner in doing lot of work regarding this ART regulation and other thing. I am really happy that she is here today. She has been in the national panel doing all the work for us here. We should be utilizing her presence here. Like if we had a little extra time, I think we should give it to her so that we can clarify. All of us who are doing ART should clarify a lot of doubts from her. Please do make little extra space for her. Thank you. Now I call upon Dr. Jaleta Helen. Madam is MD, DGO. She has completed her diploma in reproductive medicine in Germany, masters in reproductive medicine UK, done specialty courses in gestational diabetes mellitus, trained in ultrasound in infertility and gynecology, presented various papers in national and international conference. She is also a very good dancer. I think she does painting and gardening. Thank you. Welcome, ma'am.
Thank you very much, Cox, for giving me this wonderful opportunity here. Good evening, ma'am. Good morning, ma'am. The topic which is given to me is a very debatable topic. Whom to select for IVF and ICSI? Which patient exactly we have to go on? Yeah. What is ICSI? So we all know, I'm not going into detail what is ICSI and what is IVF. Intracytoplasmic sperm injection is a specialized form of IVF that is used primarily for the treatment of severe cases of male factor infertility. ICSI involves the injection of a single sperm directly into the mature egg that we all know. And IVF, it is a fertilization which is done in vitro. It is an assisted reproductive technique. In vitro fertilization is a procedure in which eggs from a woman's ovary are removed and fertilized with sperms in a laboratory procedure, hence in vitro. So this is the general basic steps what we do in ICSI. So what are the criteria for ICSI? ICSI IVF is recommended for the couple who have had poor or no fertilization during the standard IVF, as well as men who have poor sperm morphology or abnormal shaped sperms, poor sperm motility, which showed very sluggish movements, a low sperm count, and obstructions such as vasectomy, which prevents sperm release, anti-sperm antibodies, a vasectomy reversal that was unsuccessful or resulted in a low sperm count or poor quality sperms. Potential risk what we face in this procedure for the egg. As ICSI is more invasive and requires more handling than standard IVF insemination techniques, there is a small chance that the egg may be damaged during the procedure, resulting in a non-viable egg. For the resulting child, thousands of children around the world has been born as a result of ICSI. So far, there is no convincing evidence that the incidence of birth defect is any difference with ICSI or IVF compared with children born other parents for similar age and health. The mother's egg at delivery, family history, and the presence of pregnancy complications are the most important predictors of newborn health. However, it is possible that a male child born as a result of ICSI might have a fertility problem similar to his father's. So these are all the common risks which we see during the process of, after the process of ICSI. In hyperstimulation, the chances of multiple pregnancy, the chances of miscarriage, and the ectopic pregnancies. So currently, the advanced sperm function test has diminished greatly since the advent of ICSI. Incidence of male factor has not increased, but the use of ICSI is 100% in many IVF centers. What are the pros and cons of ICSI? Assessment of oocyte maturity and the quality before the insemination. This has to be, we should consider this. Low incidence of fertilization failure, comparable main outcomes, extra layers of caution in PGD cases. And the cons requires well-trained embryologists and equipments, long-term effect on the health in under scrutiny, though no definitive evidence. Based on emerging data, attitude may be revised. How do we decide on whether to use ICSI or not? We have to select the patient correctly for ICSI. The most probable indication would be severe male factor, testicular epididymal sperm. If the morphology is less than 4%, according to the latest guidelines, previous failed fertilization. If the young couple with unexplained infertility, then half ICSI and half IVF. Want oocytes and ICSI not used for the low oocyte yield, advanced maternal age and poor oocyte quality. What is the purpose of semen analysis? Usually what we see, we are trying to predict the fertility potential of a male. Does he have any sperms or not? Is the sperms alive, motile? Can the sperms fertilize an egg? This is the main things which we focus on when we see a semen analysis. Fertilization sperm function test is coming up. It is not coming up. Actually, the use has been increased in the in abroad. Actually, I think Priya Kannan madam will be a better person to talk about that test. Egg fertilization is the true measure of sperm function. The requirement of fertilization, what we see here is ZP binding, acrosomal reaction, zone penetration, egg attachment, and egg activations. But the advanced test which usually is advised is HPA binding test, AR test, and 24 hours survival test. So AR test validated with IVF. Our AR test results were validated by IVF fertilization rate. Important steps to believe test results. AR test validated with human IVF to demonstrate that a poor AR test score translated to poor human IVF fertilization. The AR test does always predict complete fertilization failure, which can occur but rather significantly reduce the fertilization. Fertilization rates for conventional insemination and ICSI. There was around 3,400 cycles over 15 years. They have put a statistics. No statistical difference between the conventional insemination and ICSI were found. The histogram at the fertilization rate showed when the ART test is normal, then the fertilization rate are the same with IVF and ICSI. ICSI does not guarantee normal fertilization. The probability of less than 50% fertilization is the same with both the techniques. So the take-home message basically is ICSI is overused today. Use for true male and egg factors. Concern with long-term impact of ICSI on children. Sperm function test can reduce the use of ICSI. Thank you.
Thank you, ma'am, but I think I would like to differ from your suggestion, because being an embryologist, though I don't go and do my ICSIs regularly, I'm more on the male factor. Okay, I'm interested in male factor infertility. But anyway, Dr. Priya Kannan would, acknowledge what I'm telling. Because, see, like, there is some problem with the sperm or the egg. That is the main issue why they have come for them. And the patient is spending somewhere around 2.5 to 3 lakhs by the time they give their gametes into our lab. And we are not supposed to take chances. Maybe, as you said, like if there are a lot of oocytes that were being retrieved, like more than 15 or 16, like during the past few years or decades or so, then I think we can go for the chances of taking 50% IVF or 50% ICSI on this. Now with the present protocols, you are eligible to only retrieve only 7 oocytes and other things and all. I think I would prefer going for a...
I think there is no confusion here.
No, the donor cycles.
The salmon oocyte is only
Donor
for
cycle. Donor,
Yes.
that's what I'm telling you. Donor cycles. I won't definitely like advise you. And second, even for the couples for whom we can retrieve till 15 oocytes or so, I would prefer most of it to be used in ICSI and only very minimal to be in IVF, because they would be doing a lot of zona pellucida, not allowing the sperms to enter into the egg. All these things they'll be coming across often while doing the ICSI procedures. So they use a lot of other procedures to break that. And I feel that ICSI should be more and less than IVF.
It's always a debate, but scientifically, Dr. Janita, what you said is right. We should not be doing ICSI for everyone. When the sperm parameters are beautiful, please go for IVF. Because, yes, fertilization rate is higher with ICSI, but the final pregnancy rates are the same. When the sperm parameters are normal. That means an IUI, a good IUIable sample, not a finely IUIable sample. When the sperm parameters are normal, fertilization rates will be slightly high in ICSI, but your pregnancy rates are the same. But why we have a problem? Yes, there is a small higher birth defects in the ICSI babies. Yes, what you said is perfectly right. We know that what we don't know is whether it's because of the ICSI procedure as yet, or is it because of the inherent genetic problems in the male because of which we are doing ICSI. So I guess that is the problem, because if it's just we don't think it's a technique, it is probably the inherent problem in the male because of which we are doing ICSI. For 1 million count we are doing ICSI, we don't know what is there in the genetic makeup.
So there's a cost difference when you do that?
No, we don't have any difference as of in India. It's all the same. We almost do ICSI for every couple. Oh, sorry.
Sorry. Okay, I come from Singapore, so our practice is slightly different. So what we usually do is we do a sperm DNA, HB for all our patients. So and if the HB is over 65, we put them for ICSI. But before we put them for ICSI, we do a sperm survival. So we either do a total motile sperm count or we do a sperm survival. And only if the sperm survival is more than 80%, then we put our patients for ICSI. It works well. The failed fertilization rate is quite little. But very few patients qualify for IVF because the HbA, the cutoff is 65%. And a lot of patients, even though they have normal semen parameters, your HbA drops. But HbA is not really a measurement of the sperm function, because HbA only tells you whether the sperm can pass through the cumulus, not whether it can bind through the zona pellucida. So but I think that's the only test which is available so far. And personally, I would give patients an opportunity with IVF, but there's a difference in cost between IVF and ICSI in Singapore. So if they're going, for ICSI, they have to pay $1,500 more. So what we do is, because of the difference in cost, and it's a woman who suffers, there's no fertilization, she has to repeat the whole cycle once again, which is very sad for her, right? The man has got a very easy job. So we counsel them about this, and if they're acceptable, we put them for IVF.
I don't think they have a cost difference, just the same.
Thank you, ma'am.
Thank you for the wonderful session anyway. Thank you.
We have 5 more minutes, ma'am. We are right on time. So, any inputs from the audience regarding the ART bill?
Talk about the ART bill.
Okay. I think everyone knows about the ART bill, ART Act, which has come around now. I hope you all have read the final notification which has come in terms of surrogacy into June, and for ART level 1, level 2 on 6th or 7th of July. That is what we are supposed to have. So the basic thing is to look at our lab setup and our qualifications of the gynecologist we are going to register, and the embryologist that we are going to register for our labs. I think those are the most important things that we need to have. Please go through it, and please comply with those things, because they are anyways going to come. We need to have a urologist as well, the MCH urology. So every lab has to have an MCH urology, a gynecologist with at least 50 pickups to be done, or an MCH with 3 years. So there's a lot of things, that's one. And then for embryologists, it's like, oh, we are confused ourselves. Sometimes I think, do I have a job? That's how it is. But then, yeah, I think I must have done at least 500 cycles, so I think I'm qualified. So there are a lot of things, please go through it. Anesthetist and a counselor, somebody who is already there can also be a counselor. So the basic thing is this. This is what they'll be looking at immediately. Your lab setup and the personnel that you have in your lab, and the clinician. So this is fun. Number 2, I think everything else is just fine, except in the third party reproduction there's some confusion. It's okay, just wait. Don't take any oocyte donation cycles or surrogacy or anything until the government decides to give you a donor. Don't take, there is no need for you to have any. And that too, in Tamil Nadu, we've had enough problems recently. So let's not foray into that topic at all. Whoever calls, I say, please don't do any oocyte donation right now. So that's something we should be very wary about. But other things, I think one thing is your PGT, they have not been able to, we've not been able to pliable with the government at all on who can have a PGT or who cannot have a PGT. That is something they are not willing to even discuss about it. They said the PGT is only for people who medically recommended or indicated. So we are yet to have that indication for that right now. So the PGT-A, the screening we used to do for rampantly for everyone is out of question from now on. So that cannot be done. So but then because we have setups where we have the PGT done and the processing of the genetic sampling is done in the same center. So there's no control. So that's why they have this difficulty of whether they're doing gender selection or not. That's a key for them. And when you want to transfer gametes or embryos from one place to another, we have to have a written permission, prior permission from the National Registry. That's something we need to keep in mind. And outside the premises. Yes, you transfer one embryo from here to another center, you have to have the permission. Both. And in terms of IUI, I think that's the most important thing. Every IUI clinic has to be registered with the government. If you want to do IUI in your clinic, please register yourself as level 1 IVF ART clinic. And for that, you don't need much. You just need a gynecologist to be there. That's all. There is no necessity to have a lab technician. You can train yourself. IUI prep is nothing. It's just as simple as that you can learn. You can just do it yourself, but you have to register yourself. But other than that, but if you are stimulating here and taking your patient to another center, that center must be registered. But in your own clinic, you cannot do an IUI unless otherwise you have registration as level 1 ART clinic.
Suppose I register my unit as level 1 and I've got everything, and suppose my colleague who's just having an OP outside, she can come and do IUI here?
Yes, but her name also should be there as one of your gynecologists. If she does, or she can do under your name.
Under my name.
But then which means you are taking the responsibility as well.
And your level 1 ART is the requisite that you should have a fire safety license. Like that. So
Ma'am, that comes.
CEA.
That's
all
CEA.
clinics, whichever CEA, all clinics comes under CEA. Whatever CEA has, you have to give.
for OPs, I don't think you need a fire.
Ma'am, that is not mentioned in the ART.
Yeah.
But then whatever the CEA needs to be, you need to comply. You need to comply with.
Ma'am, as far as CEA is concerned, the single consultation room will you will not need a thing. But when you have a ART level 1, you cannot show it as a single consultation.
So here you are generating biomedical waste. So it becomes a proper hospital setup.
Okay.
You need to have your biomedical ways, you need to have fire safety, you need to have everything else accordingly.
Dr. Priya, I have a question for you. See, most of the gynecologists rely on the local labs for the semen analysis. That we come across on day-to-day practice. Now, how that work? Because I come across lot of semen analysis reports which doesn't have a format at all. And sometimes when I go and look at the sperms or whatever the analysis again, it's totally different.
Yeah.
So whether they'll be able to depend on the labs,
Always,
local
I
labs.
think when you are investing in an IUI lab, I would definitely recommend you investing in one andrology technician and training them to do a proper SAM. Instead of sending to a local lab, all the local gynecs can send it to the IUI level 1 clinic where there is a trained technician who can give a good SIR report rather than sending it to some godforsaken lab where he gives 80% normal sperms. You are looking at, wow, we are better than Superman. And it's like that. So invest in a laboratory technician who can do a good SIR and also do your semen prep. That works out well. You can your friends will all be there, OB-GYN friends. They can all make use of your andrology technician to have the semen analysis also done. That way it's better because we from AS, we've been trying to push and train all the pathology technicians also for semen analysis. They don't come forward to get trained. They'll give 80% normal sperms, 90% normal sperms. God forsaken, from where they get it, we have no idea. But that's how they do, which means they don't have an idea of semen analysis.
Ma'am, I have a question. Ma'am, so medical college hospital, madam, suppose we register for level 1 ART, so we keep on, the faculties come and go. So do we need register every time that the name should be included in that bill, or the hospital is registered?
This works the same as your PCPNDT.
Okay.
So you keep changing names, you deleting some names, adding some names and all that stuff. You have to keep doing that. You have to inform the authorities of any change in your gynecs in level 1. In level 2, you have to keep reporting to them about every change in the gynec, embryology, urologist, andrologist and anesthetist. Every time there is a change, you will have to inform them. Just like your PSCPND.
Or else you keep one name and as she told the other person will have to do under this person.
But then in medical college, that's not possible. They keep transferring and stuff like that. You have to keep informing them.
Okay, thank you.
I think that person's name also should be included in your registry there. Suppose your friend comes and does your IUI something, her name should be there.
Yes, as a guide.
Otherwise,
if you do, you take the responsibility.
So when we register itself, it is wise to register all the people who will be coming and doing it.
exactly. Another concern is about the egg donations, right?
Yes, ma'am.
That 7x. Do we still hold on to the 7x?
It still remains a 7x. You can use the 7M2s. You please use the 7M2s for fertilization and store the rest of the M2s to be used for the same patient. You freeze them and keep them.
Why not you take them as end use, which is a better survival than...
Ma'am, that the law has not told us also.
But,
We will stick to the law, ma'am, for now. After 2 years, we'll look for some amendments,
what
ma'am.
I'm asking, okay, if I collect 15 eggs from the donor, for example, 7 and then 8, okay, who is the size for the same person?
Yes, ma'am, you freeze the oocytes to be used for the same patient. You cannot use that oocyte for another patient, also for the same patient. Now,
One thing that I would ask, as the embryologists, they have made very strict rules. They can't work in the many centers and all. So what is on that? So you just, for the, I think one is for the medical college. You can counsel your students. So you just put a light on this part.
ma'am, I think now it's the time that MBBS students, I think from when I was doing embryology to now, a lot of MBBS students have started showing interest in embryology. After me, I think we have had at least about 10-15 people going only to Monash to do embryology, all doctors. So I think I was the first person to go to Monash, and after that so many people have gone. And it's very nice. Embryology is it will become another specialty for MBBS doctors also to do, because the government has allowed us to do also, not just You have to do a MSc in any MSc in postgraduate in any course with I think 3 years of experience, postgraduate of 2 years and then experience, or a PhD in embryology or fertility with 1 year of experience, MBBS or BVSc, veterinary science also with the postgraduate in embryology and then 2 years of experience, or I'm also confused about, I keep forgetting all those things, but yeah, it can be. Students can take that up as a specialty to do as well, and it is offered in very few courses as well. There are some universities such as Chettinad used to, or SRMC, which takes only doctors to train as embryologists, because UGC has not allowed them to take any other field to train as embryologists. But whoever is having an embryologist now, so what to do about the embryologists who are presently working? As a one-time measure, the government has given us allowance that whoever fits this criteria, that is, they must have done at least 500 cycles, including ICSI, and at least 100 cryo cycles. If anybody qualifies to that, a graduate or a postgraduate, then they can be called as embryologists right now. But anything less than that, you cannot even show them as embryologists. Ma'am, whoever comes for inspection now.
They should be present, right?
Yes. So if I am there, I am the lab director in my center, I can give my assistant, yes, she has done 500 cycles. With 100 cycles of it's a center, it's the magnanimity of the center and the lab director which works, which makes or breaks the career of my juniors now. That's why I've been telling people that be generous. They have been working here for 10 years and so. Be generous in giving them certificates so they can make a living out of it. Where else will they go after 10 years of working here? They've made
In level 1, what about donor IUIs?
Yes, donor IUIs can be done. Why not?
Can be done.
You can do, but then you just have to source your from the ART bank.
That should be registered, and there should be written in this thing that you will be bringing this.
Yes, you will plan. So today morning, we can't do IUIs. So you will have to plan, say that I'm going to have an IUI for this particular patient with this particular whatever papers they're asking.
When I'm registering itself, I should say I'm going to get my sample from such and such a bank.
No, I don't think so.
Okay,
As of now, we don't know. As of now,
the procedure, like you have to. How is the form handled?
We don't know. We don't know.
Ma'am, you have to register as you will be doing both donor and cell IUIs. That's all. That's the thing. At present, it's being given in the application form. But when you are sourcing, it should be from a registered bank. ART bank. These are two different things.
We don't know it.
Yeah. Thank you.
That's my only question that I also have in mind, ma'am, that I've stopped all third party in the sense of no surrogacy, no oocyte donation. I don't know whether to stop the donor IUIs also.
Because we get this funds from the reputed
Banks.
Or we have things from the NAB.
I don't know, ma'am. That's a question that I also have in my mind, ma'am. Should I wait for that also? Yes, ma'am.
There was a WhatsApp message. There was a WhatsApp message that for a donor IUI you can use fresh semen. It was not allowed before, but there was a message. I don't know if it is true. Fresh semen can be prepared and used.
Ma'am, ethics is fluid, no, ma'am. What is ethical to my society is not ethical to another society.
If you talk to the recipient, they are not happy to see the donor, and they don't want to go with the donor to the magistrate to form the affidavit. They say, we don't want to see the donor. Why are you forcing us to see the donor? I said, that's the law.
Yes, ma'am. It's
They said
difficult.
they have problems in future.
Yes, ma'am.
Thank you very much.
It's not a mess. We will get to know the guidelines, I mean the law, and we will learn to follow. But we have to follow. That's all. And it's already started. It's already started. So from now, everything is in place. 6 months down the line, it started. So everything is in place. July, ma'am. they gave it out on 25th of Jan. So from there 6 months and everything, actually from the day one it is gazetted, it is in vogue. It's just that they gave a slight leverage, but then July first week they gave us a final notification and that's it. We are into the law right now, completely.
The state has taken fees?
Ma'am?
They have accepted
No ma'am, here in the state, that is a state body ma'am.
Yeah,
The
so
state
that is also accepting this.
Ma'am, they have just formed the body in Tamil Nadu, so they are yet to start doing all that stuff. But I suggest that all of you please go to the online thing and register your clinics. It should have been done by yesterday or day before. If you have not done, 22nd July was the last date. If you have not done, it's okay. You can also do it now also. Please do it.
Thank you, Doctor. I think we can wind up this session and we can proceed with the next one. Thank you very much.
Thank you so much. That was a very interactive session. May I request Leela Vyas ma'am to come on to the dais to honor our chairpersons, Dr. Anuradha ma'am and Dr. Shanti ma'am. Photographer. Ma'am, just a sec, ma'am, just a sec. Documentation is missing, ma'am. Photographer.
Wait, let me check.
Thank you, ma'am. Can we have the session one speakers on stage, please?
Ma'am.
Dr. Indu. Dr. Indu, Dr. Indra, and Dr. Jalita.
Ma'am?
Sorry.
Thank you.
Thank you so much. We move on to the session 2. The chairpersons will be Dr. Anuradha ma'am and Dr. S. Vijayalakshmi Poonamali. Madam has done her MBBS in Sri Devaraj URS Medical College in 1987 and has around 28 years of experience. Diploma in OG in Sri Ramachandra Medical College in 1998. She is a trained infertility specialist. She has done her diploma in reproductive medicine from Kiel, Germany, diploma in reproductive medicine from ICOG2. She is joint secretary of Conjurum Obstetric Society, executive member of Women's Doctors Wing, IMA Thambaram. She is winner of poster presentation on psychological evaluation of infertile couple in ISA 2018. Her special interests are in ultrasound and infertility. We welcome you, ma'am. Kindly introduce the speakers and call them on stage, ma'am.
Yeah, the first session will be capsule presentation by Dr. Dharani. She is a final year postgraduate, SRM Medical College Hospital and Research Center, and she is a MBBS from the PSG Institute of Medical Science and Research.
Good morning to everyone present here. Today I am going to give a talk on melatonin. So melatonin is N-acetyl 5-methoxytryptamine. It is an indolamine hormone. It is secreted from the pineal gland. It was first recognized in the 1950s, but even 70 years before its recognition, the doctors told that patients with pineal gland tumors had some puberty related derangements. So from then on, there has been a study going on the relationship between the pineal gland and the reproductive function. And then in 1950, the melatonin was first recognized and it was found to play a major role in the circadian rhythm. And it is secreted during the dark hours of the night and its half-life is around 20 to 40 minutes. So the precursor for the melatonin synthesis is the tryptophan amino acid, and it is produced in the mitochondria of the pineal gland cells. And once it is produced, it is not stored in the glands. It immediately enters the circulation. Once it enters the circulation, it acts on various organs and tissues in the body through its receptors MT1 and MT2. So the half-life of melatonin is from 20 to 40 minutes, and the receptors have been found in various organs, and when compared to the reproductive organs, it is found in the hypothalamus, pituitary as well as the ovary. So when it comes to the role of the melatonin, it has various roles. Like its main role is it plays an important role in maintaining the biological clock. There is a circadian rhythm. Then it also scavenges the free radicals, especially the reactive oxygen species as well as the nitrogen reactants. So it has a very important role as an antioxidant. As a result of which, it has a role as anti-inflammatory, anti-tumor, anti-aging, immunomodulation, and reproductive regulation. So as an antioxidant, in the recent years, it has been told that melatonin is twice as active as vitamin E. The reason one being it is highly lipophilic, and it is a free radical scavenging action. So because of its antioxidant property, it is told that it helps in the optimal functioning of the cells. So when it comes to the reproductive organs, the effect of melatonin on female reproductive physiology are mediated via its receptors in the hypothalamic, pituitary and the ovarian sites, and hence it has a protective effect in female reproductive organs. So its role in fertility and reproduction, so it regulates the production of FSH and LH in the gonadotropic cells, and the reduction in the FSH and LH levels protects the body from the risk of early entry into puberty. So oxidative stress is told to be one of the main reasons for female reproductive system disorders like PCOS, infertility and endometriosis. So PCOS patients have higher levels of oxidative stress when compared to healthy women. So because of its antioxidant effect, so we can tell that the oxidative damage can be prevented by melatonin, and hence it has positive effects in PCOS, premature ovarian failure and ovaritis. So in PCOS, normally it is told that the serum melatonin levels are higher in PCOS women when compared to normal healthy women. But in contrast, interestingly, so the follicular fluid also has melatonin. The follicular fluid melatonin level was told to be higher in normal healthy women when compared to PCOS women. So an RCT trial in 56 women with PCOS who had received melatonin for 12 weeks had demonstrated that there was a decrease in hirsutism and testosterone as well as in the oxidative stress markers. So thus administering melatonin, it reduces the apoptosis of the critical cells, thereby it helps in the development of pre-ovulatory follicles to develop into a mature oocyte. And Pacciarelli et al. In 2015 in Italy had done a RCT trial in 165 PCOS women, and he had given melatonin 3 mg for 14 days, and there was, the results were there was increase in the number of mature oocytes, and intrafollicular concentration of the melatonin was found to be 4 times higher when compared to the control group. Similarly, in Italy in 2017, a study around 40 PCOS women who were given melatonin 2 mg per orally for 6 months showed that there was a significant reduction in the androgen levels, and FSH levels were also significantly raised. In 2018, another study in Iraq conducted among 50 PCOS women who were given melatonin 3 mg per day for 2 months showed that there was a decrease in LH level and decreased BMI. And another study in IVF also, like they had told that melatonin plays an important role, like it is useful. Like women who have failed in their previous IVF cycle were grouped into two. One group was treated with melatonin per orally from day 5 of their cycle till the day of the oocyte retrieval, and another group was not treated with melatonin. So the group who was treated with melatonin, they saw that the pregnancy rate was doubled. And thus melatonin treatment in PCOS, it has beneficial effects in reducing the hyperinsulinemia and reducing the androgens, reducing the body mass index as well as the intra-abdominal fat, and during the ovulatory process, the scavenging activity of the melatonin plays an important role during ovulation, and it also helps in improving the menstrual cyclicity and its role in oocyte maturation. So follicular fluid melatonin has an important role than the serum melatonin. They say that the melatonin levels in the follicular fluid has an important role in the growth and maturation of the oocytes. So melatonin concentrations are higher in larger follicles. So as the follicle grows, the melatonin level increases, and the melatonin level increases than that of the serum melatonin level. So interestingly, but the intrafollicular melatonin level is considerably lower in PCOS patients than the healthy women, which can lead to the reason of anovulation and low oocyte quality in PCOS women. So when we administer melatonin, it causes increase in the prostaglandin and cytokines, so which reduces the oxidative stress by the reduction of the reactive oxygen species, and therefore the oocytes are protected from the oxidative stress and helps them to develop into a mature oocyte. Recently, BMC published that melatonin treatment for 6 months was able to restore the menstrual cyclicity in women with PCOS by significantly decreasing the androgens and significantly raising the FSH levels. And melatonin in pregnancy. So not only in reproduction, melatonin also has an important role in pregnancy. It helps the mother as well as the fetus. It has significant effects on both mother and the fetus. So first, it crosses the placenta. The melatonin production increases during pregnancy. So the melatonin is also secreted from the placenta. So as the gestational age increases, the melatonin levels also increase in pregnancy. And its antioxidant function, it scavenges the reactive oxygen species and reactive nitrogen species, and it also increases the antioxidative enzyme. And this melatonin also crosses the placenta, and it has effects on the fetus too. So the reduced melatonin production. So in pregnancy also, patients with preeclampsia, chronic placental insufficiency and obese patients are found to have lesser melatonin levels. So when it comes to the fetus, it lowers the risk of fetal growth restriction, and it limits the hypoxic damage, and it limits the oxytocin levels. It increases the progesterone production. And it also helps in reducing the severity of preeclampsia by reducing the vascular endothelial damage, and it also limits the likelihood of eclampsia. So in obese patients, since the melatonin is deficient in pregnancy, so there is a lack of circadian melatonin rhythm in mothers, so which eventually leads to the lack of the circadian rhythm in the offspring also. But offsprings born to non-obese mothers who had a normal melatonin levels during pregnancy had a significant circadian rhythm to a lesser extent from the 3rd postnatal day onwards. So it is therefore an important regulator for the mother, placenta and fetus interface. Other than this, recent studies have shown that melatonin also plays an important role in the management of asphyxiated infants. So newborns, asphyxiated newborns, there was a study conducted on asphyxiated newborns. They were grouped into 2, and one group of the newborns were given melatonin and another group was not given. And the group that was given melatonin had a better survival rate, but this study is like, there are many more studies to be done on this topic, like asphyxiated. Thank you.
One second, ma'am. Madam, before we move on to the keynote address, I take immense pride and privilege in introducing Dr. Vani ma'am today. Ma'am has graduated from Tanjavur Medical College, done her DCS from Tanjavur Medical College, MD OG from MMC. She's worked in the Department of OBG in almost all medical colleges in Chennai and HOD in few medical colleges outside Chennai too. She's retired as Dean from Thiruvannamalai Medical College. Presently, she is head of the Department OBG in Sri Balaji Medical College and Hospital. She's got a lot of publications in national and international index journals. We welcome you, ma'am.
Thank you. Thank you. So it's a very good presentation, Dharini. You got done everything from PCO to mother and fetus, everything. It's a very good. So it's a great. We welcome our next speaker, Dr. Hemastri Rajesh. She's a first UG. She's from Singapore. And she is a fellowship in St. George Hospital, IVF, Australia, Sydney. She is also a senior coach. She is also a course director of SOUL. She is starting out of an assisted reproduction workshop. You welcome me, madam.
Thank you very much for the kind introduction. I've been enjoying the conference, and I know that this topic is very dry. So what I've done is I've interspersed with a few clinical facts so that it would help you in your process of personalized IVF stimulation. So, So to begin with, the oocytes begin as primordial cells within the yolk sac of the fetal ovary, and then what happens is they migrate to the ovary where they differentiate into oogonia. And then they enter a process of mitosis and they keep increasing, and the cell number keeps increasing. From around 3 months of fetal gestation, what happens is some of these oocytes become differentiated. They enter the prophase of the first meiotic division, and by 5 months of fetal gestation, you can see almost all of them have entered the prophase of the first meiotic division, which means they've already differentiated into oocytes. So thereafter, there's no increase in number. And then what happens is these oocytes become surrounded by granulosa cells from the surrounding mesonephros, and they all turn into primordial follicles. So a woman's ovarian reserve is set when she's around 5 months of gestation inside her mom's womb. And it's not just the genetic factors which determine the ovarian reserve, it's also epigenetic factors. So if she's going to be a smoker, she's exposed to polycyclic aromatic hydrocarbons. There might be some leaching of BPA from plastics, that she can be exposed to phthalates, benzopyrene. So all these will determine her ovarian reserve. And then what happens to these primordial follicles is they have 3 courses of action. They can either stay put, they start to develop, or they can directly enter apoptosis. If they start to grow, all they can become till puberty is just antral follicles. So at any one time, around 0.1% of this residual pool gets activated, and it's constantly deactivated. So there's a decrease in your oocyte count till puberty. And as I told you, the growth is only till an antral follicle. So a primordial follicle is just a naked egg. It has very few granulosa cells. And as it becomes a primary follicle, it acquires a zona pellucida. The granulosa cells increase in number. And thereafter, it acquires a thecal layer and becomes a secondary follicle. And finally, a small antral cavity to become the antral follicle. Until puberty, because there's no gonadotropin support, the granulosa cells will apoptose and the thecal cells will merge into the surrounding stroma. So this period of growth is called as a gonadotropin independent growth, and it lasts for almost around 90 days. And what triggers this growth is hyposignaling. So for the transfer from a primordial follicle to a primary follicle, you need this hyposignaling pathway. And it helps us to know about this pathway because suppose you've got a patient who's referred for chemotherapy and the patient comes to you for fertility preservation. It makes sense to keep her follicles in the primordial stage because in the primordial stage, they are more resilient to chemotherapy. On the other hand, so currently there have been some research into this mTOR inhibitors. I think the name is rapamycin or something like that. And these mTOR inhibitors can keep your follicles more in the primordial stage. Similarly, suppose you've got somebody who's 38 years old or 40 years old, comes to you with a poor ovarian reserve. And in this patient, you want more eggs. So it makes sense for us if we can stimulate these primordial follicles and get them to be more primary follicles so we can augment further growth. And currently, there's been some research into this also, and that is the concept of in vitro activation. So in this paper published by Punawala, I think quite recently, there are 2 processes by which you can turn these primordial follicles into primary follicles. One of which is just a mechanical mincing, something which is practically possible. So what you do is you can do a laparoscopy, you can take a portion of the ovarian cortex, mince it into small bits, thread it onto probably a vital thread and just suture it back into the ovary. And this has shown to work. There's not robust evidence, there's still not an RCT, but there is some promise. And some researchers, they've also done some ovarian scratch similar to this, all of which will mechanically activate the process of transformation of the primordial to the primary follicle. Similarly, there have been publication of reports of P10 inhibitors. So if you use a P10 inhibitor, what happens is once again your primordial follicle can become primary follicles. But with the use of P10 inhibitors, these follicles have an accelerated apoptosis rate. So currently it's still not, probably the mechanical activation is a better way with a little more evidence. So moving further, what happens is with the onset of puberty, you get gonadotropins into play. The patient starts to have, the young girl starts to have gonadotropins FSH. And what happens is these antral follicles become gonadotropin responsive. And they have to be gonadotropin responsive for around 3 months till they mature enough to become the dominant follicle which we will stimulate in our IVF. So what we measure as anti-Mullerian hormone is a glycoprotein which is secreted by the granulosa cells of all the follicles from the primary follicle right till the early antral follicle. So if you're going to measure your AMH, you're measuring this entire pool of follicles. Whereas if you're going to measure your AFC for your antral follicle reserve, you're only going to measure your mid-antral follicles, which are between 2 to 8 millimeter or 2 to 10 millimeter. So you've got a better idea of your immediate response to the ovary with your gonadotropins. So in our center, we measure antral follicle count, and traditionally we've been taught that you should measure your antral follicle count between day 2 to day 4 of menses. But in this interesting paper by Van Dieseldorp in 2010, he showed us that the antral follicle count is almost similar throughout the menstrual cycle. There is probably a slight increase in the antral follicle in the luteal phase, but this is statistically non-significant. So personally what I do is I measure antral follicle count between day 8 to day 10 of menses, because by day 8 to day 10 of menses your endometrial lining is very thin, so if there's a polyp you can identify, and if you're planning to transfer in a fresh cycle, it helps us make a decision. And as to what is a normal antral follicle count, we've all been governed by the Rotterdam criteria, which told us that anything more than 12 follicles per ovary is polycystic ovaries. But you should remember that the Rotterdam criteria was established in 2003, okay, and it was only from 2 papers, and 1 paper only had around 200 subjects. And currently, from 2003 to 2022, our transducers have become much more better. So what we previously saw like this is currently seen much more better. And so, in this paper in 2014, Develi has shown that in a normal ovary, probably the upper limit of a normal antral follicle count is around 20. So much so you need an AFC count of almost around 35 to 40 to term your patient as a polycystic ovary if you're using transducers which are at least 8.5 megahertz and above. So in our center, we don't have an upper limit to qualify as a peak cause, but we have a lower limit of the antral follicle count for a poor responder, and our lower limit is an AFC of 12. So which means internationally what is accepted as a low AFC is an AFC of less than 5. So you've got to validate your center, what probe you use, and you have to decide what is the antral follicle count which defines a poor responder or a normal responder in your circumstance. Moving to those of you who use AMH as an ovarian reserve, you should know that you should only probably start using your AMH from around 25 years of age, because though AMH is secreted just prior to birth, it takes time for it to equalize in the circulation, and the negative correlation of AMH with age only starts around the age of 25. You should also know your lab, what assay your labs are using, because sometimes if your lab uses older assays, there is a difference in the AMH because between your collection and your storage. You should also know your patient when you use your AMH, because if your patient is going to be on long-term oral contraceptive pills, or if she's going to be a smoker, have some chronic diseases like probably some renal disease, lymphomas, or hypo, then the AFCs or the AMH is not reflective. This is one of our young patients. She was 25 years old. She had a residual secondary hypopituitarism because she had a pituitary surgery for Rathke's cleft cyst. And you can see she wanted conception. So the endocrinologist stopped the OCP 6 months prior to the fertility consult. And as you can see, even 6 months later, the AMH and the AFC is so little, so minimal, and the FSH and the LH are super suppressed because of her hypo. So we gave her a guarded prognosis, and we stimulated her using this as a junction. And then you can see 3 months later, because 3 months we gave her some growth hormone and we gave her some estradiol, because her uterus was super small. It was only around 8 mils. So we wanted to grow the uterus. And by the time she started her stimulation, the AFC was 13, which is still, in our setting, is considered to be a poor ovarian reserve. And you can see once we gave these patients gonadotropins, she just boom burst with follicles. So your AFC of 1 and your AMH of 0.1 is, your AMH of 0.1 and your AFC is definitely not reflective of this patient who's a hyper-responder. So beware of hypopituitarism. And nobody exactly knows how a oocyte decides that it's the one which is going to grow. But once the oocyte decides, it's the master of the ceremony. So what the oocyte decides is it starts to secrete some paracrine factors such as bone morphogenetic protein, growth development factor, etc. All of which will go and act on the surrounding granulosa cells. And the granulosa cells will start to mature. A polyhedral cell will become a cuboidal cell, which is the first sign of maturation. And for this maturation to occur, you need an intact FOXL2 gene. So you don't have a FOXL2 gene, once again you will go into premature ovarian failure. And these are candidates for fertility preservation. And what happens is, thereafter these granulosa cells will start to develop gap junctions between themselves for communication, because the granulosa is an avascular layer. Simultaneously, what happens in the theca is hormone synthesis starts to occur. For this hormone synthesis to occur, cholesterol is taken from the blood and is transported into the mitochondria of the cell. So from the cytoplasm, it goes into the mitochondria, and the carrier for this is the star protein. So if you do not have a star protein, what happens is patients develop a condition called as congenital lipoid adrenals. So there's lipid everywhere in the cytoplasm, but no hormones. And if you've got a male child, they will be raised as females, because initially there's no testosterone production at all. So and finally, after the cholesterol is transcribed to androstenedione, it becomes estradiol within the granulosa. So if there's any problem in any of these processes, you'll have follicles, but you have ovarian failure. Okay, and if you want to know exactly what is the problem in your patient with primary amenorrhea, you can do such genetic panels like the ART guide, which will pinpoint what is the defect in your patient. But this is purely of academic interest, doesn't serve us practically. You can't do anything for these patients except oocyte donation. So let's move on to the gonadotropin responsive follicles. So once a follicle becomes an early antral follicle, it has a thecal layer, so it can secrete some androgens. And what happens to these androgens is they will promote the development of FSH receptors within the granulosa cell. So with the onset of puberty, you get gonadotropins, you get FSH in the circulation. And what FSH does is it promotes aromatase secretion within these, aromatase formation within the granulosa cells, so that the thecal androgens can be converted to estrogens. Androgens, in addition, also help with the growth of the follicles. So they promote granulosa cell mitosis, so your follicles become larger. But once a follicle hits around 6 millimeter plus, what happens is it cannot accumulate any further FSH receptors. So it stays put after this. So in the presence of follicles which have accumulated high amount of FSH receptors, they will have higher aromatase, and the follicles will become more and more estrogenized, and they will start to grow. But on the contrary, if you have the smaller follicles with low aromatase, the androgens will convert it to more potent androgens, and these follicles will become atretic. So that is what happens when you get a premature LH surge. When you get a premature LH surge, the theca makes a lot of androgens. And what happens is these androgens will tend to push these follicles towards atresia. So you get more atresia with the premature LH surge. So now that we know that androgens can help us increase recruitment, how do we use it practically? So what has been tried is DHEA, testosterone, and letrozole. And what the theory is that these androgens are supposed to bind to the granulosa cell, and because they bind to the granulosa cell, they start to promote the mRNA expression of the FSH receptor, and they also increase IGF-1. So that basically these follicles become more recruitable. So you get a pseudo PCO-like state. You have more follicles which are recruitable, and your poor responder may have more eggs. And so does it really work in practice with letrozole given between day 2 to day 6? No, it does not, because I told you that the gonadotropin responsive phase for a follicle is 3 months. You need 3 months of androgens for the follicle to become mature and respond to your, become FSH dependent. Okay. What about DHEA and testosterone? There have been several meta-analyses which say, okay, fine, there is some evidence that if you give androgens prior to stimulating your poor responder, that there's going to be a moderate increase in your live birth rate. But you've got to take this with a pinch of salt, because most of our studies from DHEA and testosterone come from meta-analysis and not randomized controlled trials. Now, randomized controlled trials are gold standard. Meta-analysis just analyzes all these and comes to a conclusion, so it's not the best way. And some of these studies are a bit biased. So as you can see, most of these positive outcomes come from studies from Barad and Glacier. And Glacier holds the patent for DHEA in the United States. And then, there's also no consensus on who exactly is a poor responder. You decide this is a poor responder, you just use it at your women's fancy. And everybody gives random doses. And sometimes some of these studies on testosterone is only for 2 weeks or 3 weeks. So we really do not know whether it works, but there is promise. And DHEA is such a mild androgen, it would rather not work than work on your patient, and it's pretty safe to use. The only side effect is a mild hirsutism, which I've never seen happen. It increases the libido, so sometimes when you give it in the West, the patients want more DHEA. And it's quite safe even without IVF. So for your poor responders, it's alright to give them a few months of DHEA. So even without evidence, many of us use it, including me. Okay? And let's go to the final phase of follicular recruitment, which is what we do in IVF, the gonadotropin-dependent follicle. So we all start our gonadotropins during menses in the antagonist cycle, which most of us do now. The reason we do that is your FSH is at the highest and your inhibin is at the lowest. Now inhibin, as you can see, is secreted throughout the menstrual cycle. The first half from the granulosa cells of the follicle is inhibin B, and the second half as inhibin A. So it's only during menses that your corpus luteum breaks. So you don't have inhibin, you have a high FSH, and your follicles start to grow. So if you're going to start your gonadotropins, remember that you should initiate them as close to menses as possible, because in the natural cycle, the FSH is increased even before menses, 1 or 2 days before. So suppose you start your gonadotropin on day 3 or day 4, what happens is, you can see this patient, there's one follicle which has already kick-started because it is stimulated by the natural FSH. So you get a heterogeneous sort of a cycle, you get 2 cohorts of follicles. So if you want to avoid this, what you can do is you can subdue this premature rise in FSH in the previous cycle by either giving estradiols or norrethesterone, or some people use antagonists. Some of my colleagues use antagonists just during menses so that it subdues the internal FSH and then they start the FSH. We call it an early shock antagonist cycle. Currently, we also know that follicles occurs in waves. So you don't only have the follicle in the menstrual phase, which we are all traditionally used to recruiting. We also get follicles in other types of the cycle. One is during the mid-luteal phase. In patients who are PCOS, you have a further wave of follicles which grow. The reason this is useful to us is you can do a dual stimulation. Suppose you've got a patient who's a poor responder. You want maximum number of eggs, you want to freeze all, and then you want to transfer the best embryo. You'll get 1 or 2 eggs in the first cycle, 1 or 2 eggs in the second cycle. So you don't need to wait for 2 menstrual cycles. So what you can do is, you can start your gonadotropins, go in quickly, give an agonist trigger, collect the eggs, and 5 days after egg collection, you can stimulate your second cycle immediately because you know that there's a luteal cohort. So in this way, the time to treat is quite short. You gain a month for this patient. But remember that you should use an agonist trigger in the first cycle. This is because if you're going to use a HCG trigger, HCG's got a very long half-life. So what it will do is the HCG will persist onto the luteal phase and it will suppress your further follicles. So you have to give higher gonadotropin doses and the next cycle will not kickstart as soon as possible. If you give an agonist trigger, not only it will release your LH, it also releases some FSH, which will help prime the immediate next cycle. So in the second cycle, it's alright to give a HCG cycle. In the first cycle, it is better to give an agonist trigger. If you're going to use gonadotropins to stimulate your follicles for IUI, remember that you can start your gonadotropins later in the cycle. Because only by day 4 or day 5, I told you the follicle will hit around 6 mm to 7 mm plus. So the FSH receptors stay put, no more increase in FSH receptors. So whatever FSH is there in the circulation will be directed to this larger growing follicle which will keep growing while the smaller follicles will atrophy. The aim of IUI is 1, 2 or maximum 3 follicles. Okay, I don't know whether you will go for 3. So you should start your gonadotropins later. Whereas if you want to do an IVF, you start your gonadotropins earlier, around day 2 to day 3 of your men's cycle. And as to decide what is the dose we want to give these patients, we've always been taught, if you look in the Western literature, they'll tell you look at the AMH, the AFC, and then you can start. And then we all get daunted by high AFCs. This is a patient in one of our clinics who had an AFC of 36 and we wanted to be super safe. Okay, so we started off with 125, nothing happened. 175, nothing happened. We increased up to 200 and then something kick-started and then finally the patient started to burst out with the follicles. This is because you have a minimum FSH threshold which you have to reach. Only after that the follicles will kick-start. And the minimum FSH should be at least about 15% above the base. So if your patient's got an FSH of 4, you've got to give her some amount of FSH to reach 6. You've got a patient with an FSH of 8, you have to go even higher. Okay, so it's very challenging, though in practice it's easy to say, in practice it's really challenging for us to get the ideal 10 to 15 oocytes. But I believe that in addition to your FSH and AFC, you should also know your basal FSH. The reason you need to know your basal FSH is because Western literature, sometimes they ask us, do you need to know the FSH? No. The answer is supposed to be no, because you know the AFC and the AMH. But I think the answer should be yes, because there are some patients with FSH receptor polymorphisms, and in the Indian scenario, it's been shown that as many as almost around 8 to 10% of the patients may have a receptor polymorphism. So what it means is your receptor is defunct. So it needs more FSH to function. So these patients will have a normal AFC, they will have a normal AMH, but their FSH will be high. It will probably be around 10 or 11. So in these patients, you have to give them higher FSH to kickstart your multifollicular development. And you should also know your weight of the patient, remember. Because the heavier the patient, the more the extracellular fluid. Sorry, is it 30 minutes already? I've got a lot of slides. Okay, I'll probably cut it short then. So because the heavier the patient, the more the FSH. The heavier the patient, the more the extracellular fluid. So it will not literally parallel but once a patient hits around 80 plus, suppose a patient gets more than 80 kg, then there's an increase in the body fat of the patient. So until 80 kg, what you have to do is you will have to increase your FSH. So instead of giving 150 for this patient, you can increase by 2 to 5. Usually we increase by 50 to 75 depending on the weight of the patient. But once your patient gets to be 80 kg and 100 kg, there's no difference because between 80 and 100, the increase in weight is capsulated as fat. It's not capsulated as an extracellular fluid. And so if you're going to, do you want me to stop?
Ma'am, we have 9 more minutes.
Okay, fine, thanks. Okay. So, I'm just through halfway. Okay. So let's move on to the two-cell 2-gonadotropin hypothesis. We are all familiar with this. The thecal cell makes androstenedione from cholesterol, and the granulosa cell will convert this androstenedione to estradiol. Okay, but what we should remember is once the follicle hits around 10 millimeter plus, the granulosa cell will also acquire LH receptor. And from then, what happens is the LH will potentiate the action of FSH. And LH can do all that FSH can do, including stimulate your aromatase. So LH will maximize steroidogenesis in patients. So what happens if you've got a patient who's hypogonadotrophic hypogonadism and you accidentally just give FSH alone? So if you give FSH alone, the follicles will still grow because you know androstenedione is not privy to the ovary. You also get androstenedione from the adrenals. So it can be taken by the blood, absorbed, go into the granulosa cell, can be converted to a little bit of estrogen. And follicles, because you're giving them FSH, these follicles will start to increase in size. So they'll be an increase in size, but the steroidogenesis is very defunct. The estradiol levels will be low. So these patients will make follicles, but they will not become pregnant. Another thing to remember is, so there are certain situations when you would need to give LH to patients. These are situations when you have a GnRH deficiency. Androgenic deficiency is common in patients whom you give prolonged oral contraceptive pills. So if you're going to give prolonged oral contraceptive pills, the HPO axis does not respond. Okay, it will not release an LH. And if you're going to use an agonist cycle, you can see that the LH is super low. You see this pink line. Whereas in a natural cycle, the LH, even around the follicular phase, is a bit on the higher side. If you're going to use an antagonist cycle, you can see that the LH periodically keeps dipping lower and lower and lower. So that's why if you're going to give long cycles with prolonged suppression, you'll probably have to add LH. If your patient is a hypo-responder, like your Poseidon group 2, you know, these are patients with a normal ovarian reserve, but in an antagonist cycle, they don't do well unless you give them LH. This is probably because once you give them the antagonist, their LH dips super low, so it's not enough for the eggs to grow. Or patients with genetic variation of the LH receptors, or women who are older. Because in women who are older, you get a defunct HPO axis, cannot secrete enough LH. And one more thing you've got to remember is the granulosa cell also has this enzyme called as 3-beta-HSD. So any pregnenolone which leaks from the thecal cell to the granulosa cell can convert it to progesterone. And this is important because though the granulosa cell can make progesterone, in the mid-follicular phase, in the early follicular phase, you never get progesterone. That is because the granulosa cell secretes the paracrine substance called as activin, and the job of activin is to go and bind to this 3-beta-HSD so that the granulosa cell will not make progesterone. But by mid-cycle, the follicle, in addition to making activin, also makes follistatin. And the job of follistatin is it will go and bind to the activin so that your 3-beta-HSD can now work and the granulosa cell starts to make progesterone. So in a pre-ovulatory follicle between day 10 to 11, you've got estrogen production, you've got a small amount of progesterone because there's already follistatin. And then what happens is this will stimulate certain LH receptors in the cell becomes luteinized, and once your estradiol hits a threshold of more than 200 picograms per mil, in the presence of a small amount of progesterone, that is your trigger for the spontaneous LH surge to induce ovulation.
So that is why if you're using a flexible protocol in antagonist cycles, it is better to go by estradiol levels. So because in an IVF we do a multifollicular recruitment. We have many small follicles which are making estradiol. So even though one follicle does not hit 12 mm or 13 mm in a flexible protocol, you've got many follicles which are making estradiol on and on. So you should go by estradiol levels rather than the follicle size. And if you've got a high progesterone level secreted prior to your ovulation trigger, if your progesterone hits around 4.7 nanomoles, the endometrium is already advanced. So even though you go and retrieve your eggs, the endometrium will not be suitable for transfer. The chance of a pregnancy drops by around 15%. And that is when you will have to consider a freeze-all if your progesterone goes super high before your trigger. As to the natural LH, once your LH starts to rise, remember that the LH has to stay above the threshold for a minimum period of between 14 to 28 hours. Only then your oocyte will mature. So for the oocyte to mature, you need this LH to stimulate your oocyte maturation factor, as well as to obtain away the oocyte maturation factor plus release prostaglandins. So while the oocyte becomes mature, the prostaglandins will open up the follicle and the egg is released. So suppose you've got a natural cycle, you've got only one egg or two eggs, and you really want to capture the egg before release, you can use NSAIDs in these cycles. So we give ibuprofen sometimes in one or two eggs, and we go in and retrieve the eggs till the morning of the oocyte retrieval. And remember, any follicle which is between 12 to 24 millimeter, there is a fair chance that you get an M2 oocyte. The size of the follicle does not matter. And if you're going to use an LH surge, remember that the LH surge is totally unpredictable naturally. So this is a very interesting paper by Park, which is quite old. But what he showed us is in normal ovulating woman, your LH surge can be anywhere like a single spike, a double spike, etc., etc., etc. Okay, so the normal LH surge is supposed to last for 3 days, but in many patients the LH surge is defunct, and so you get a defunct luteal phase. So even if you're going to use your LH surge for your IVF cycles, we use LH surge in our spontaneous natural IVF cycles to do embryo transfers. What we do is we always substantiate them with HCG so that you've got a nice, good progesterone in your luteal phase. And what LH does is, as I said, it gets your oocyte to proliferate further so that your what is just a mass of chromosomes or a germinal vesicle starts to become more organized like spindles, and finally extrude the first polar body to become an M2 oocyte. Remember that it's only the M2 oocyte which can be fertilized, because only the M2 oocyte has an N complement of chromosome. All these others, your GB and your M1, have a 2N set of chromosomes, so they can never be normally fertilized. Sometimes if you get your M1 oocyte and it matures for a while outside, it can still be fertilized, but the chances of a best pregnancy are from an M2 oocyte. And as for the trigger, we are all used to our traditional HCG triggers. The HCG trigger is very good because it lasts for a long time. It lasts almost up to 6 days in the circulation of the patient. Immediately after you give your HCG, 2 days later, what happens is your progesterone starts to increase in the circulation, and the intrinsic progesterone due to the HCG is present up to day 8. So from day 9, what happens is the embryo starts to secrete its own HCG if it's viable. And by day 11, the patient can make enough progesterone to support her own self. But there is a gap in the practice. Between day 8 to day 11, you definitely need a luteal support. And in IVF cycles, your intrinsic LH is not going to kick in because you have a high level of estradiol and progesterone from your multifollicular recruitment. So you definitely need to give progesterone for these patients. More so if you've got a GnRH agonist trigger, because if you're going to have a GnRH agonist trigger, you can see that the spike is very short. So your progesterone probably will only last till day 2 or day 3. So we use GnRH agonist triggers in our practice very widely. We do fresh transfers because we always give these patients HCG if we think there's a less risk of hyperstimulation. After we've collected the eggs, by then the estradiol has come down after you collect your eggs and you can assess your patient better. And then what we do is we give them a small dose of HCG there, and with this HCG support, the patient goes on to have great pregnancy rates. As is unpublished data, but we do it all the time. So we give the HCG dose around any time between 1000 to 1500. And if you're going to give an LH, GnRH agonist trigger, remember once again, if your patient's got a low intrinsic LH, like these patients who are super suppressed on oral contraceptive pills, they will not be able to initiate an LH surge. And in some centers, they will, after you give an LH for triggering, you will measure the LH, and after you give a GnRH for triggering, you will measure your LH and progesterone in the blood. We don't do that in our center because we've never had a GnRH agonist trigger and never not retrieved eggs, unless we accidentally did it in an agonist cycle. You know, sometimes we forget in an agonist cycle we give an agonist trigger, and then of course you will not get eggs. So that is entirely iatrogenic. So after that, of course, you're going to, that's the end of the egg because it's going to become an embryo henceforth. So this is the end of my presentation. Thank you.
An elaborate presentation starting from physiology up to pathology you went in, and the clinical presentation cases which side by side you gave were very interesting. Thank you. And thank you all the way coming from Singapore and helping us out.
I think it's been a very great conference. I really enjoyed all the presentations. I found it so useful, and I hope to continue to stay today and get more facts. Thank you very much.
Thank you. Thank you. Thank you, ma'am. Now I request Shamundi Shankari ma'am to come over to the stage to honor the chairpersons, Dr. Vani ma'am and Dr. S. Vijay Lakshmi.
It's my honor to receive from my madam because I did my ICOG from my madam, from madam and Dr. Divya.
Sir, அங்க அப்படியே அங்க
சார் நான் தெரியுமா
Can we have the speakers on stage, please? Dr. S. Dharani and Dr.
Thank you.
Our secretary, Dr. Omiyal ma'am is here. Ma'am, please join us on the stage.
Thank you.
Thank you so much. PG. One second.
Thank you.
Years of professional experience in the field of fertility. She is a former professor of microsurgery, OG, at Government Kilpack Medical College. Madam has received Lifetime Achievement Award from His Excellency the Governor of Tamil Nadu in the field of fertility services. She is the founder and chairperson of Srishti Fertility Hospital Private Limited, a 100-bedded multi-speciality hospital. She is also a managing trustee of Srishti Medical Research Foundation. She has a lot of achievements and awards adding feather to her cap. We welcome you, ma'am. Dr. Vijay Lakshmi Kandasamy ma'am is professor, Department of OG at Chettinad Hospital and Research Institute. Her undergraduation was in Stanley Medical College. Madam has post-graduated from KMC Manipal, Karnataka. Ma'am has got 16 years of teaching experience for UG and PG. She is mentoring several batches of students. She is also chairperson of WDW of Valacheri IMA. She is member of OXY and life member of Indian Menopause Society. Her areas of interest are high-risk obstetrics, adolescent gynecology, infertility and gynec endoscopy. Welcome, ma'am.
At the outset, I would like to thank the COGS for this great opportunity to chair a session at their very vibrant conference. and I take great pleasure in co-chairing the session with me, a very senior member of the IVF, and I look upon Madam Chamundi Shankari. Madam, I know her since almost more than a decade, and it's a great honor to be chairing the session with her. And at the outset, first speaker for the session, I would like to call upon Dr. Padmaja. She's a consultant OBGYN and managing director of Lakshmi Hospitals, and visiting consultant at SIMS Vadaparni, who's graduated from Calicut Medical College and her DGO from MMC and MRCOG. She has her basic lab training from St. Paul's at Cochin, and her areas of interest are high-risk pregnancy, general gynecology, and she has presented at various CMEs and has conducted several awareness camps, village health camps, as well as part of the NSS camps as well, and breastfeeding awareness and midwifery classes. And she's here to talk to us about a problem, I would say, that is increasing now, obesity in pregnancy. The dais is yours, Dr. Padmaja.
Thank you, madam. A little bit of obstetrics in between the infertility panel. Good morning. So we are here to talk about obesity in pregnancy, which is a looming problem, increasing day by day. And what is the big deal in it? Let's see. Obesity has become the most common medical condition in women of reproductive age, and the rising prevalence of obesity is seen in both high-income countries and low and middle-income countries. It is predicted that by 2025, more than 21% of women in the world will have obesity. In US, it is 2/3 of women of childbearing age are obese or overweight. In UK, it has increased from 9 to 10% in the early 1990s to 16 to 19% in the 2000s. In Indian subcontinent, the prevalence of obese or overweight women rose from 11 to 15% in 2005 to 2006 as per NFHS survey, and now it's to 20.6 as per survey 4. Obesity increases the risk of non-communicable diseases such as type 2 diabetes and cardiovascular disease, which contribute to 70% of global deaths annually. This is especially important in the low and middle income countries, where 86% of premature NCD deaths occur. Obesity during pregnancy also increases the NCD risk and transfers the risk to the offspring through epigenetic mechanisms, alterations in gut microbiome, and socio-cultural factors. Obesity in pregnancy causes an increase in GDM and type 2 diabetes mellitus. Later on, it also causes LGA babies and metabolic compromise in the offspring, and other long-term consequences including poor cognitive performance in the child and neurodevelopment disorders including cerebral palsy. It causes increased complications like varices, cholecystolithiasis, thrombotic complications, anemia, UTI, intradiagnosed type of skin disease, exertional dyspnea, bronchitis, hypoventilation, and breathlessness. So this is the classification, the category of given by the WHO, where we are supposed to do the BMI calculation of every antenatal woman. It's not enough that we just check the height and weight, we have to calculate the BMI. And if you look into the chart, the cutoffs or the ranges are different for Asian women and the European countries. Measures that are better predictors of health outcomes include BP measurement, waist circumferences, and blood sugar levels. Abdominal obesity is most strongly associated with morbidity and mortality compared with the accumulation of fat around hips and thighs. Waist circumference has therefore been used as a better measure of visceral adiposity and associated risk. BMI is also able to distinguish between muscle and it's unable to distinguish between muscle and fat mass. So two individuals with the same BMI could have very different body compositions. Across different populations, a given BMI may not correspond with the same degree of fatness, and the BMI range considered to be healthy may vary between populations. Despite these significant limitations, BMI is still considered the most useful population level measure of obesity. So the topic is pregnancy, obesity complicating pregnancy, but it starts with the pre-pregnancy care. So primary care services should ensure that all women of childbearing age have the opportunity to optimize their weight before pregnancy. Advice on weight and lifestyle should be given during preconception counseling or contraceptive consultations in a non-judgmental way. Weight and BMI should be measured to encourage women to optimize theirs before pregnancy. The non-judgmental way is very essential. No body shaming, not an expression on the face of the doctor, or else the patient will not come back to you. She will continue with her lifestyle. As per SOGC baseline, preconception health screening involves the renal function test, liver function test, thyroid function test, lipid profile, diabetes screening, doing blood pressure checkup, echo and pulmonary function tests. A practical diet and lifestyle advice, correction of nutrition deficiencies such as vitamin D, iron, vitamin B12 are needed. Women should be counseled that weight loss between pregnancies reduces the risk of stillbirth, hypertensive complications, fetal macrosomia and increases successful payback. They should be informed about the increased risk of miscarriage, gestational diabetes, preeclampsia, VTE, induced labor, dysfunctional or prolonged labor, cesarean section, anesthetic complications, PPH and wound infections, and mortality and failure of breastfeeding. So what are the nutrition supplements pre-conception? Women with a BMI 30 kg per meter square or greater wishing to become pregnant should be advised to take 5 mg folic acid supplementation starting at least 1 month before conception and continuing during the first trimester of pregnancy. Obese women are at high risk of vitamin D deficiency, but whether routine vitamin D should be given to improve maternal offspring and offspring outcomes remain uncertain. Cochrane concludes that vitamin D in a single or continuous dose reduces the risk of low birth weight, preterm birth and preeclampsia. The RANZOB also recommends 150 microgram of iodine, correction of iron deficiency, dietitian advice, referral for bariatric surgery in class 3 obesity. So what are the recommendations for women LADs coming to you post bariatric surgery? An increasing number of women who have undergone bariatric surgery prior to pregnancy. Common types of bariatric surgery are laparoscopic banding, sleeve gastrectomy and gastric bypass. So data regarding the safety and long-term efficacy of this approach continues to evolve. The women often need to be on lifelong vitamin supplementation and referral to a dietitian should be instituted. The nutrition supplementation required will depend on the type of bariatric surgery. So they should be advised to avoid pregnancy immediately post-surgery. At least 1 to 2 years afterwards, the surgery is the ideal time when they should conceive. The OCP may be compromised by unreliable absorption in women who have undergone gastric bypass surgery and LRs, such as so we can use an LRC or implant an IUD as a preference, not an OCP. Bariatric surgery reduces GDM-LGA but increases IUGR. Shorter gestation, stillbirth, but no difference has been seen in LSA's rates, risk of PPH and preterm delivery. So a patient coming after bariatric surgery also, she has some risk of IUGR and shorter gestation and stillbirth. So before we are taking up a patient who is obese, category 1 or 2, what is the essential things we need to have? All maternity units should have an environmental risk assessment regarding the availability of facilities to take care of pregnant women with a booking BMI of class 1 or greater. The risk assessment should address the following issues. There should be circulation space, accessibility including doorway widths and threshold, safe working loads of equipment and flows, appropriate theatre gowns, equipment storage, transportation, staffing levels, availability and procurement of equipment including large blood pressure cuffs, appropriate sized compression stockings, pneumatic compression devices, sit-on weighing scale, large chairs without arms, large wheelchairs, ultrasound scan couches, ward and delivery beds, mattresses, theatre trolleys, OT tables and lifting and lateral transfer equipment. This actually happened in my OP when an obese lady came and sat on my consultation chair. The chair cracked. I prevented her from falling. So we may think this is all a small issue, but it's not like that. We put her on an OT table. She's 130, 140. It's very difficult. A list of details of safe working loads, product dimensions, as well specific compound is located. How to access it should be provided for class 1 obesity. So for a woman with booking BMI of 40 more, clear communication of manual handling requirements should occur between the labor and the theatre suits in early labor or even in the 3rd trimester itself. So measuring weight, height and BMI. All pregnant women should have their weight and height measured using appropriate equipment and their BMI calculated at the antenatal booking visit. So it's essential that we have to calculate the BMI, not stop with weighing up, doing the height and weight measurement alone. For women with obesity and pregnancy, consideration should be given to reweighing women during the 3rd trimester to allow appropriate plans to be made for equipment and personnel required during labor and birth. While Ramsar recommends weighing the women every trimester, NICE advises weighing the women not as a routine. Though I think we all do a weighing every antenatal visit. That's what we all practice. The Institute of Medicine recommends different ranges of weight gain based on BMI, but they are practically difficult to adopt routinely in clinical practice. So what is the diet and exercise advice in pregnancy given? Patients should be advised that only about 200 kilocalories of extra need is there in the last trimester. So about 150 minutes of exercise per week is advised. Anti-obesity and weight loss drugs are not recommended in pregnancy. Use of topiramate is linked to oral clefts in the baby. Topiramate and phentermine are also excreted in breast milk, hence not recommended in lactation too, due to unknown risk on the infant. So this is a common scenario where a primary gravida, comes with a UPT positive, the whole family is very happy, and the first question she asks is, "Madam, what should I eat?" Or the family asks. Already she would be 10 kilos overweight. So first thing is to make her aware that she's overweight. Obese patients, they may know that they're obese. To make them aware that they're overweight, so already you're excess. So what is essential is controlled weight gain, and there's no need for you to eat lots, at least in the first 2 trimesters. That has to be told. So what is the risk assessment for anesthesia? Pregnant women with a booking BMI 40 more should be referred to an obstetric anesthetist for consideration of antenatal assessment. Difficulties with venous access and regional and general anesthesia should be assessed. In addition, an anesthetic management plan for labor and birth should be discussed and documented. Multidisciplinary discussion and planning should occur where significant potential difficulties are identified. Obesity is associated with increased cardiac arrest during anesthesia. Increased risk of difficulties with airway management, including difficult bag and mask ventilation, failed intubation, higher risk of desaturation when difficulties encountered, and post-operative atelectasis are encountered. Hence, primary and secondary airway plans need to be made. Obesity is associated with significantly higher gastric volume in laboring patients, and also an increased decision to delivery time due to difficulties in provision of general and regional anesthesia. Obese patients have increased chance of developing pressure sores, hence should have plans for skin assessment, skin care, repositioning frequency, and pressure redistribution devices put in place, which we very commonly see. A post-LCS patient, she doesn't move. The next day or immediately we find that she has a bed sore. It's very fast because they don't move. Screening, diagnosis and management of gestational diabetes. All pregnant women with a BMI 30 or more should be screened for GDM at the earliest. There is a risk of 0.82% increase in GDM for every increase of 1 kg per meter square by BMI. But again, in our Indian scenario, since by racial consideration we all fall into high risk category, so it's a default that we do a glucose challenge test for every woman, whether she's obese or not, at the first visit. Obese women have 3-fold increase in GDM, and obese women in GDM have a 3-fold increased risk of congenital anomalies. It is also recognized that women who have undergone bariatric surgery may be prone to dumping syndrome following an oral glucose tolerance test. So dumping syndrome is thought to arise due to malabsorption, osmotic fluid shifts, and postprandial hyperinsulinic hypoglycemia, and may result in a number of symptoms including flushing, palpitation, syncope, abdominal bloating, diarrhea, and sometimes even altered consciousness. To avoid these symptoms, an oral glucose test is not recommended for women who have had bariatric surgery. Instead, home blood glucose monitoring for a period of at least 1 week has been suggested for the purpose of screening for gestational diabetes in these women. So, screening, diagnosis and management of hypertensive complications. An appropriate size of BP cuff should be used for BP measurements at all consultations. This is a very important thing because already we are dealing with a lady who has one risk factor as an obese lady. And if you are using a smaller cuff, you are going to get a higher BP, and automatically you are going to add to the list of a complication. The whole management changes. We may put her classifier as a preeclampsia or gestational hypertension, whatever it is. The whole management changes. So we should have an appropriate size BP cuff in our consultation room. Less error was introduced by by using a too large cuff than a too small cuff. So class 2 obesity and greater have an increased rate of preeclampsia compared to a non-obese population, which we all know. So low-dose aspirin 100 to 150 mg per day reduces the risk of preterm preeclampsia. It is more effective taken at night and has to be started between 12 to 16 weeks gestation and stopped at around 36 weeks. Consideration should be given of taking 1500 to 2000 mg of elemental calcium per day. In high resource settings, FIGO recommends the use of uterine artery pulsatility index, placental growth factor and serum pregnancy associated plasma protein for preeclampsia screening, that is in high resource settings. So VTE prevention, screening and diagnosis, BMI more than 30 or greater or at booking should have a pre-existing risk factor for developing VTE during pregnancy. So we should have the VTE chart in our room and we should be able to classify which category she belongs, when should we, whether we need to start her on antenatal heparin, when at what gestation, based on the number of risk factors she has, not only the obesity. So risk assessment should be individually discussed, assessed and documented at every antenatal visit, and intrapartum and postpartum thrombophlebitis is given. Obesity is a risk factor for VTE with risk of pulmonary embolism due to reduced mobility, a comorbid condition that predispose to thrombosis such as preeclampsia and increased frequency of operative delivery. In obese women, higher levels of coagulation factors 8 and 9 are seen, and any state of hyperestrogenism like an OCP or a pregnancy triggers a VTE. So that's the reason why they, other than the immobility, so the rise in the coagulation factors is one thing which makes them more vulnerable for a VTE development. The RCOG recommends routine measurement of peak anti-DNA activity for a woman weighing 90 kg or more on therapeutic lows of low molecular weight heparin. So another issue is a mental health problem which I don't think we address in our setup. Obese women are at increased risk of mental health problems and thus should be screened in pregnancy. Depression is very commonly seen, needing psychological support and suitable referral. There have been links between childhood neglect and childhood sexual abuse and adult obesity. There is insufficient evidence to recommend specific lifestyle intervention to prevent anxiety and depression among obese pregnant women. Postpartum anxiety eating disorders are also increased in obese pregnant women. Vaccinations and medication dosing. RANSA guidelines strongly recommends influenza and COVID-19 vaccinations for pregnant women with obesity. Folic acid supplementation is 5 mg rather than our standard dose. VT prophylaxis based on maternal weight. Low dose aspirin 60 mg for preeclampsia prophylactic increased to 100 to 150 mg. Prophylactic antibiotic dose at the cesarean section need to be increased based on the body weight. What about screening for chromosomal anomalies? All women should be offered antenatal screening for chromosomal anomalies. Women should be counselled, however, that some forms of screening for chromosomal anomalies are slightly less effective with a raised BMI. Consider the use of TVS in women with who it is difficult to obtain NT measurements transabdominally. There is an increased possibility of failure of NIPT in obese women due to low fetal fraction. Obesity prevents from obtaining accurate NT measurements, and in such cases, women should be offered second trimester screening with serum markers. So, fetal and neonatal complication, fertility and miscarriage, there is higher risk. There is doubling of risk of stillbirth. Threefold risk of spina bifida, omphalocele and heart defects in babies of obese mother are seen. There is an association between maternal obesity and spina bifida heart defects and anorectal atresia, hypospadias, limb reduction defects, diaphragmatic hernia and omphalocele. Increased risk of fetal macrosomia, 20% in obese women, in turn leading to increased operative delivery, low Apgar score, a low umbilical artery pH, shoulder dystocia leading to increased fractures and nerve palsies. So screening for structural anomalies during pregnancies, it has limitations because of the obesity. However, women should be counselled that all forms of screening for structural anomalies are more limited in obese pregnant women. Clinical assessment is also not perfect, and USG also finds it difficult to identify anomalies, but still USG is better. Fetal anomaly scans would be more time consuming, and repeat USG at a later gestation can improve identification of cardiac structural anomalies. Serial growth scans in third trimester can be done for growth assessment, but still shows only low sensitivity. Fetal monitoring antenatally. Serial measurement of symphysospinal height is recommended for each antenatal appointment for 20